evening. This is Karen Parry, Manager of Information Services at the East Brunswick Public Library. I'm so happy to welcome Ashley Purper, who has a master's in public health. Ashley is a community cancer control specialist with the Rutgers Cancer Institute of New Jersey. As part of the community outreach and engagement team, she is responsible for educating the community on various cancer prevention and screening topics through workshops and other outreach opportunities. Ashley obtained her Bachelor of Science in Biology from Westchester University and began working with the Cancer Institute after obtaining her Master of Public Health degree in 2021. Welcome to this evening's program entitled Tobacco Use in the LGBTQ+ community. And now I'm going to turn it over to Ashley. Welcome, Ashley.
Great, thank you so much. And thank you for having me back. I know this is a bit of a series, so you'll be hearing from me quite a few times this month. So just give me 1 second to pull up my screen. All right. Is the screen up? I'm not able to.
Yes.
Okay, great. Well, again, thank you for having me. My name is Ashley Purper. I use she, her pronouns. I am a community cancer control specialist with the Rutgers Cancer Institute of New Jersey. And tonight we're going to be talking a bit about tobacco use behaviors in the LGBTQ+ community. Just before we really dive in, I just want to note that the information contained in this presentation is not a substitute for medical consultation. A physician should always be consulted for any health or medical condition. This is really just for educational purposes only. Again, I like to reiterate that this is a judgment-free zone intended for learning and growth. My email is here up on the screen, so if you do have any questions post-viewing, feel free to send me an email and I will get back to you when I'm able to. So the objectives for today, we are going to review some terminology. If anyone watched my previous workshop, we went into this in great detail. Tonight is just going to be a brief overview just to refresh everyone's minds. We are going to understand smoking rates and smoking behaviors in the LGBTQ+ community. And then we are going to talk very briefly about best practices in affirming programs. And then we will have a resource discussion at the end. So I do like to start each workshop with a little pre-test. It's obviously not graded. I understand many of you may be watching this at a later date. So feel free to pause, write down your answers. These are all true/false statements. We will launch this again at the end of the workshop and we will see if your answers changed or maybe you learned something throughout the presentation. So the first statement, again, these are all true/false statements, is sexual orientation and gender mean the same thing. Is this true or false? LGBTQ+ populations have higher rates of tobacco use when compared to their non-LGBTQ+ peers. The tobacco industry has been known to target the LGBTQ+ community. And tobacco smoke has more than 7,000 chemicals in it. Again, all true/false statements. We will talk about the answers at the end of the presentation. So like I said, we are going to start with briefly discussing some terminology, just so when we go through the presentation, you have a basic understanding of some of the things we will be talking about. So firstly, I want to talk about the acronym. What does it mean? What do all these letters mean? So LGBTQ+ is an umbrella term used to describe all sexual and gender minorities. The plus sign is often used at the end of the acronym, which is used to describe any orientation or expression that is not listed out in the acronym itself. So firstly, we have the letter L, which stands for someone who is lesbian. And this is someone who identifies as female, being attracted to other people who identify as female. Then we have the term gay, which means someone who is attracted to members of the same gender as themselves. Most of the time it is used to describe men who are attracted to other men, but it can be used to describe women who are attracted to other women. Then we have the term bisexual, and this really means someone who is attracted to members of the same gender as themselves, as well as other genders. And I want to note that this doesn't need to be an equal or 50-50 split in attraction. It just means someone who is attracted to members of the same gender as themselves, as well as others. Then we have the letter T, which stands for trans or transgender. This is someone who does not identify with the sex they were assigned at birth. For example, if you were assigned female at birth and identify as a man, you are a transgender man. Finally, we have the letter Q, which means queer. Queer is also really just an umbrella term used to describe sexual and gender minorities. It's sometimes used interchangeably with that LGBTQ plus acronym. You may hear it kind of bouncing back and forth tonight with LGBTQ plus and queer. I do recognize that it sounds a bit controversial. Queer has been used as a slur throughout history, but many have been working to reclaim the term, and it is now seen as that umbrella term. Again, I mentioned that sometimes, most of the time, it's written with a little plus sign at the end, and the plus sign is used to describe any orientation or expression not listed out in the LGB or T. I just want to say you may not know all the terms. That's okay. LGBTQ plus people use a variety of terms to describe their identity and to talk about who they are. Just listen, pay attention to how people are talking about themselves, and then mirror their language. We really just want to respect that self-identification and trust that that person knows who they are. Some terms that the plus sign might represent are up on the screen here. We have pansexual, asexual, genderqueer, gender fluid, pangender, omnisexual. There's really over 100 different terms that this plus sign can represent. So I'm not going to really describe these in detail. We could be here for days if we did that. So again, just keep in mind, respecting that self-identification, mirror the people's language when they speak about who they are. Next, I just want to talk about the difference between sex assigned at birth, gender, and sexual orientation. So to start off, sex assigned at birth refers to the label that your doctor gives you when you are born, based solely on anatomy medical features. If your doctor writes M for male on your birth certificate, that means you were assigned male at birth. And if they write F for female, that means you were assigned female at birth. On the other hand, gender refers to your innermost concept of self as a man, a woman, a blend of both, a combination, or in some cases, you don't identify with either man or woman. So your gender identity may be the same as your sex assigned at birth, or it may be different. Again, for example, you were assigned male at birth, you identify as a woman, your gender identity may be a transgender woman, and your sex assigned at birth is male. And last but not least, we have sexual orientation. This refers to who you are attracted to. I mentioned before some of the terms, lesbian, gay, bisexual, pansexual. These all refer to a person's sexual orientation. Keep in mind that this can change throughout the course of a person's life, and just to respect that self-identification. I want to point out that knowing someone's gender identity does not tell you anything about their sexual orientation, and vice versa. These are really two separate components of your identity. So now we're going to really talk about tonight's topic, tobacco use, tobacco behaviors. So I want to point out that research documenting the health disparities among LGBTQ plus individuals is growing, but there is still limited national data available regarding tobacco use among the community. The most current national data for LGBT youth and adult tobacco use rates are from 2016. So we really have this need to improve research in the community, but all the data that is available indicates that the LGBTQ plus community is disproportionately impacted by tobacco. I have some facts here on the screen. 20.5% of LGBTQ plus community members partake in the use of tobacco products. Lesbian, gay, and bisexual adults are more likely to use cigarettes and twice as likely to use e-cigarettes. Transgender adults have higher odds of using cigarettes, e-cigarettes, hookah, and cigars. In 2021, 24.5% of transgender high school students use tobacco products. This is more than twice the rate as their cisgender peers. In addition to using tobacco products at higher rates, youth sexual minorities were more likely to use tobacco more heavily. Between 2020 and 2021, e-cigarette use rates rose at higher rates among lesbian, gay, and bisexual youth compared to heterosexual youth. Approximately 36% of LGBTQ plus smokers report smoking menthol cigarettes, compared to 29% of heterosexual or straight smokers. This may seem like a bit of an odd statistic to put in here, but this will make sense a little bit more down the road when we talk about the difference between cigarettes and what menthol may do. And I don't really want to sit here and bore you by reading a bunch of percentages and statistics. But again, all trends do point to the fact that queer youth and adults are more likely to use tobacco products and use them more heavily when compared to their non-queer counterparts. If you are interested in reading more, the truthinitiative.org actually has a great webpage dedicated to this topic. And that is actually where I pull a lot of this information from. So here on the screen, we have two graphs that just highlight some of the things I was mentioning before. On the left side, we have lesbian, gay, bisexual adults compared to straight adults and their current cigarette use. This, again, is as of 2016. You can see that the sexual minorities are this dark pink, magenta line here. You can see that both in male, female, and in all adults, that rate is a lot higher. And in this graph here on the right, we have transgender youth versus cisgender youth, current tobacco use as of 2016. Again, the transgender youth is this dark purple color, this bottom line. You can see that it is significantly higher in smokeless tobacco use, cigarette use, e-cigarette use, and even the use of more than one product. So these people are using e-cigarettes and cigarettes, or they may use smokeless tobacco and regular cigarettes. Again, you can see that the rates are much higher for transgender youth when compared to cisgender youth. So I want to point out some factors that may influence tobacco use and some reasons why this community may be seeing these trends at higher rates. So there's really this desire to fit in with peers. Oftentimes members of the LGBTQ+ community feel, ostracized from those around them. So when they find a group that they feel they belong to, or they find a community they feel they belong to, and they see that group smoking, they begin smoking as a way to fit in. Smoking is often used as a negative coping strategy to deal with and mitigate the experiences of minority stress. Those in the LGBTQ+ community are seen as a marginalized minority population. One thing I want to mention here, when I was looking into some of this, I found an interview with a young woman who was part of the LGBTQ+ community that admitted to using smoking as a negative coping strategy because she actually used to partake in self-harm. And she said smoking gave her that same relief she felt from self-harm. So in her mind, she was doing herself a favor by smoking instead of self-harming. But in a way, smoking is also self-harm. There's often socializing in venues that permit smoking. There's a large bar culture among the community. There's exterior and environmental stressors that accompany disclosing one's LGBTQ+ identity, really that stress of coming out to those around them, or the stress of feeling like they have to hide who they are. There has been aggressive targeting of the community from the tobacco industries. We will talk about this a bit more on the next slide. There's also just an overall lack of culturally competent providers and culturally competent social services. Again, if you're interested in hearing a bit more about that, there is another video up with my previous talk that talks a little bit more about some of these topics. So in the United States, LGBTQ+ people are about 2 times more likely than straight people to take up smoking. Tobacco companies know this and work hard to make sure it continues. Tobacco companies use a multitude of methods to target the LGBTQ+ community, including advertising in gay press publications, showing tobacco as a normal part of the LGBTQ+ life. They use corporate philanthropy as evidence of their support of the community. They participate in giveaways, they increase advertising, they host community outreach efforts at some of these LGBTQ+ bar nights where they feature a specific cigarette brand or e-cigarette brand. And we've been seeing the same trend in e-cigarette and vaping companies. I have some examples on the screen here of different advertisements that tobacco and e-cigarette and vaping companies have used. And you can see that they're all really trying to capitalize on that concept of pride. And I feel like that is very relevant, especially now that we are in June. This is Pride Month, that these companies really try to capitalize on that. Oftentimes, sponsoring Pride festivals and events is a major factor. Some Pride events have stopped accepting money from tobacco companies, but it is still a massive source of funding for these giant Pride events that we see. According to the Cancer Action Network, LGBTQ+ adults spend over $2.6 billion on cigarettes every year. And again, these tobacco companies know this, and so they keep marketing to the community that they know is spending money. So real quick, I do love using videos in my workshops and presentations. I do think it is great to get viewpoints from many different people. So I have a 2-minute video here. This is Dr. Scout. He works at Health Equity at Centerlink, and he's going to talk a bit more about smoking within the community.
Smoking is the largest preventable cause of disease and death in the United States. Lesbian, gay, bisexual, and transgender Americans smoke at much higher rates than average, so they suffer more smoking-related death and illness. Dr. Scout directs the Network for LGBT Health Equity at Centerlink. Here, he talks about what smoking does to LGBT communities.
Unfortunately, lesbians, gays, bisexual, and transgender people don't even realize that we smoke more than other populations. And at the same time, the tobacco control movement often doesn't realize we do too. As the next generation comes out and tries to find their leaders, they see people are smoking, and it keeps, it's really like a socially transmitted disease. While many of us are really outraged, a lot of us do not understand that we even have a disparity.
The tobacco industry has a long history of marketing to the LGBT community.
There's a lot of community gratitude for the tobacco industry, which has moved in early and swiftly to be LGBT community supporters. We also saw the tobacco industry spending more money on telling us how great they were with our rights and issues than they were even spending on supporting us. And we've seen the industry twist our civil rights issues to look like that freedom to smoke is like civil rights for LGBT people. We also really need the regular tobacco control programs to routinely include LGBT-tailored work. I mean, we have a huge history of discrimination against us in the healthcare arena, which means that we're not going to trust you unless you prove that you're different than the history. So if we see the policymakers prioritize LGBT tobacco stuff, that will be one of the best ways to help the community realize it, get educated, respond, and build the infrastructure as well.
This video is a production of the Office of the...
One thing I want to point out that Dr. Scout had actually mentioned was that he views this as a socially transmitted disease. And he mentioned, young people, when they're starting to discover who they are and they're starting to come out, they're looking for that peer group. They're looking for leaders within the community. And if they're seeing those leaders and their peer group partaking in tobacco use, they're more likely to take it up as well, just to feel like they fit in and feel like they belong somewhere. So I just want to take a moment to talk about really what is in a cigarette. There are approximately 600 ingredients in cigarettes, and when burned or combusted, cigarettes create more than 7,000 chemicals, and at least 70 of these chemicals are known to cause cancer. And it's really the nicotine found within tobacco products that make them super addictive. But just knowing that at least 70 of the chemicals that get released from cigarettes are carcinogenic. They are known to cause cancer. Why is this important? Well, tobacco use is the single most preventable cause of disease, disability, and death in the United States. And so that's why it's really important to know and understand the smoking and tobacco use behaviors, and to really understand these social determinants of health that can lead to increased smoking risk. And tobacco cessation really begins with these social determinants of health. We can improve these to create environments where people don't start smoking in the first place, or to better create environments where they are more likely to support cessation within the community. So smoking, I think we all have heard, smoking causes lung cancer. But smoking can damage nearly every part of your body. It can cause cancer of the larynx, the esophagus, the trachea, stomach, liver, pancreas, cervix, bladder. It has a strong connection to colorectal cancer. And has a strong link to many other chronic diseases, such as stroke, pneumonia, diabetes, rheumatoid arthritis. It really suppresses your immune function and just overall diminishes your health. So again, stopping the use of tobacco is probably one of the most important things you can do for your health. Again, the big thing here, though, smoking does lead to lung cancer. Smokers are 25 times more likely to develop lung cancer when compared to people who never smoked. Smoking causes about 80 to 90% of all lung cancers in the United States. And smokers today, which you can actually see in this graph here, are at a greater risk of developing lung cancer than they were when cigarettes really first, I guess, came to be. You can see that these gray bars show lung cancer risk for smokers, and then the little gold bar is the lung cancer risk for non-smokers. You can see how these gray bars have grown over the years. And this can be due to, cigarette design changes, such as the adding of filters, adding of vent holes, creating menthol cigarettes, which leads to deeper inhalation. There could also be a changing chemical composition of cigarettes. So the reason I pointed out menthol and the statistic we said before that LGBTQ plus people are more likely to smoke menthol cigarettes is menthol was created to almost ease the pain of inhaling cigarette smoke. So when you smoke menthol cigarettes, it has that cooling effect on your throat and your lungs. So you're smoking more often because it doesn't hurt as much. You're able to inhale deeper with each cigarette because you're getting that cooling sensation. So those who use menthol cigarettes may be at an even higher risk just because they're smoking more. And again, LGBTQ plus people are more likely to smoke, and they smoke at higher rates, making them way more susceptible to developing lung cancer. So I do want to point out some other causes of lung cancer. Cigarette smoking does cause around 80 to 90% of all lung cancers, but there are other risks, including exposure to radon, continuous exposure to secondhand smoke, exposure to other substances, including certain workplace exposures like asbestos, arsenic, diesel exhaust. If there's a strong family history of lung cancer, and then just some other risks and causes that are still under investigation. But a few things I want to point out here, specifically to the LGBTQ plus community, is overall, LGBTQ plus people are less likely to seek preventative healthcare services, meaning they are less likely to see a doctor regularly. They're less likely to talk to their doctor about maybe their smoking risks or their risk of lung cancer. I also want to point out the issue of secondhand smoke. As I mentioned, there is that increased smoking rate in the LGBTQ plus community. So even if you don't smoke, but all your friends do, and all of the events you go to, there's a lot of smoking, you're going to be continuously exposed to secondhand smoke. And the other thing is this family history of lung cancer. I think I mentioned at the beginning that LGBTQ plus people are often ostracized from their family. They don't have a strong family connection. They may not have the greatest relationship with their family members. So they may not know their family history as well as we would hope in terms of, disease risk and everything. So that's just another issue we see within the community. So I do want to talk a bit about lung cancer screening. So the United States Preventative Services Task Force, the USPSTF, they did expand their guidelines recently for annual lung cancer screenings, and now recommend screenings for adults ages 50 to 80 who have a 20-pack year smoking history and currently smoke or have quit within the past 15 years. A person's pack year is determined, there's a little bit of math here, which is why it's great to talk to your physician or someone who deals with cancer screenings a lot. They can help you work through this math. So a pack year is determined by the number of packs of cigarettes smoked per day multiplied by the number of years that they smoked. So for example, 20 pack years is equal to 1 pack a day for 20 years, or 2 packs a day for 10 years, or whatever math that may come between that. The previous recommendation had been 30 pack years and for ages 55 to 80. So they have expanded the age range of eligibility a little bit and have cut it down from a 30-pack year history to a 20-pack year history, meaning more people are now eligible for these lung cancer screenings. So lung cancer represents one of the most frequently diagnosed cancers among gender minority patients. However, nationwide data indicates that only 2.3% of transgender individuals have received this low-dose CT scan, which is the lung cancer screening. It is the standard of lung cancer screening. But this is compared to 17.2% of cisgender individuals, despite having similar eligibility rates. So what this is really showing is that only 2.3% of eligible transgender people who are eligible for a lung cancer screening, only 2.3% of them are actually getting the screening, while 17.2% of cisgender individuals are getting this screening. So there's we not only see disparities in how much people smoke or how often they smoke, but also in who is seeking the proper preventative care for it. But why is lung cancer screening important? So unfortunately, lung cancer, like many other cancers, you don't really see symptoms until you're at a later stage of disease. And when you hit those later stages, these diseases become much harder to treat. Only about 16% of lung cancers are detected at that early stage, where they are much easier to treat. And about half are detected at these very late stages where the cancer has metastasized to other parts of your body, spread to other parts of your body, and treatments are much less effective at that point in time. So we want people who are eligible to get screened, because then even if something is found, they do find a cancer, it is more likely that they are finding it at an earlier localized stage where it is easier to treat and you have better outcomes. But again, LGBTQ plus people often delay or forego preventative healthcare due to some of the reasons Dr. Scout said. There's been that mistrust within the community. There's a lack of health insurance. So they're not seeking this preventative healthcare, meaning they're less likely to receive the proper screenings. And one thing I do want to note, one of my colleagues actually brought this up to me, is sometimes if you can't get people on board with something just due to health risk, you can tell people, smokers know that, it causes lung cancer. A lot of times that's not what really triggers people to quit. A lot of times it is money, once you show them how much money they're spending on cigarettes. But another thing you can really appeal to is someone's vanity. Like, they want to look good, and you can tell them, tobacco use can actually affect that. And one of the important things I want to mention here is if someone is undergoing any type of gender affirming surgery, really any surgery, but tobacco use while before the surgery and after the surgery can actually affect the healing of the surgery. So quitting smoking before surgery can lower your risk of complications. The earlier you quit, the better. Abstaining from tobacco use is also recommended during recovery from surgery. Smoking can inhibit proper healing. Nicotine narrows blood vessels, which reduces blood flow and cuts the amount of blood and oxygen reaching these surgical areas, meaning they won't heal as fast or they won't heal as well. Smoking during recovery from surgery also increases the chances of infection at the surgical site, because smoking does limit your immune system function, and this can result in skin tissue death of the tissue around the surgical site, meaning things won't heal as well as you would hope for them to. So I just have one slide on some best practices on what we can do moving forward, both as a community, as maybe a healthcare professional, a healthcare provider, whomever may be watching this. So we can work to improve data collection on topics including tobacco use rates, perceptions, and disease risk in the LGBTQ plus community. Really start focusing on better data collection. Like I mentioned, the most recent national scale data is from 2016, and we're coming up, about 7 years ago at this point. Oh, time is flying. So we can really work to improve that. We can promote and ensure access to cessation services and reduce barriers to care for the LGBTQ plus community. We can create affirming tobacco cessation programs. As Dr. Scout noted, that these industries really need to routinely include LGBTQ plus people and really show that they're different and really work to build that trust back. Addressing mental health concerns and other social determinants of health that leads to tobacco use. Mention and include LGBTQ plus symbols and people in advertisements, flyers, client handouts. Build stronger relationships with LGBTQ plus organizations and health centers. And collect this sexual orientation and gender identity data on intake forms. If anyone watching this is interested, again, you can watch either the previous video or reach out to me. I do another workshop that talks a lot more in depth on these best practices. But I know tonight's focus was really the tobacco resources and everything, so I didn't want to go too deeply into this, but it is something we can talk about at a later time. And now I just want to spend a few moments talking about resources that are available to people in the state of New Jersey. So as I'm sure you've heard me say probably 1,000 times tonight, LGBTQ plus individuals use tobacco at higher rates and more heavily due to targeted advertising, societal pressures, and stress. I want to note all the services you see on the screen are completely free. We have the National Cancer Institute smokefree.gov. They have a specific part of their site with resources dedicated specifically for the LGBTQ+ community. The National LGBT Cancer Network Outlast Tobacco Initiative is a dedicated quit line for those of the LGBTQ+ community. They do also have a texting option if you're uncomfortable, talking over the phone for whatever reason. And then we have our New Jersey Quit Centers and the New Jersey Quit Line, which are available to anyone in the state of New Jersey looking to quit tobacco. Oh, didn't mean to do that, sorry. Here's just some more information on those quit centers. They are located in several counties across the state. So wherever you are located, there should be one relatively close to you. And if not, you can always, call in and get the help virtually. This is also a great time to mention this great resources by the Inspira Quit Center. They have a specific LGBTQ+ quit group. It is virtual, so no matter where you are in the state, you're able to join. It is dedicated to the community. It's tailored to the community. This Quit Center offers a welcoming, supportive, and safe environment for everyone. So again, it's just something I want to put out there that if this is something you were looking for, it is available to you. They do, again, meet virtually, so it doesn't matter where you are located. Another great resource I like to just mention in all of my workshops is the NJ SEED program, the Cancer Education and Early Detection Program. It's run by the New Jersey Department of Health in collaboration with many local agencies and healthcare systems. This organization provides education and outreach within the community about different types of cancer. They also provide free screening for different types of cancer to those that are unemployed, underinsured, or uninsured, or face barriers to getting the cancer screenings they need. They currently provide screening for breast, prostate, cervical, and colorectal cancer. This program is offered in at least one location across all 21 counties. So again, I know the topic of tonight was, tobacco use and lung cancer, but as I mentioned, tobacco use is linked to almost every other cancer as well. So if that is something you are concerned about and you are uninsured or underinsured, there are resources that are out there to help you. Another great resource I want to mention is actually one here at Screen NJ. We have a patient navigation team that is able to help connect community members to cancer screening services. This is it's free of charge. It is available to anyone, regardless of citizenship status, regardless of insurance status. Really, as long as you live in New Jersey, you can give them a call if you're interested in getting connected to cancer screenings, and they will connect you to somewhere local to your location. Again, this is statewide, completely free. They can help with other barriers to receiving the screening, such as transportation, language barriers, anything like that. So we have made it back to our post-test. Again, I know many of you are watching this kind of at a later date, so feel free to pause, write down your answers, see how they compare to your answers at the beginning. Again, they are all true, false statements. So just giving everyone a moment, if they wanted to pause, they can. If not, we will talk about the answers now. So sexual orientation and gender mean the same thing. This is a false statement. Sexual orientation and gender identity are two separate parts of your identity. One doesn't tell you anything about the other. So if you know someone's gender, don't assume their sexual orientation, and vice versa. LGBTQ+ populations have higher rates of tobacco use when compared to their non-LGBTQ+ peers. This is true. The tobacco industry has been known to target the LGBTQ+ community. Again, this is true. I think we saw all of those advertisements really trying to capitalize on the concept of pride. They really use those rainbow of colors to really push their marketing. And tobacco smoke has more than 7,000 chemicals in it. Again, this is true. When it is burned or combusted, it releases more than 7,000 chemicals, and at least 70 of them are known to cause cancer currently. So thank you for joining me tonight or logging on and watching this. If you are able to, we do have a quick evaluation survey that I would love for you to complete. It takes maybe a minute and a half of your time. This will just help me improve my programs going forward, and will also help the Cancer Institute improve their programs moving forward. But again, thank you so much. If you have any questions, my email was up at the beginning of the presentation. Feel free to email me if you work in healthcare or are a healthcare organization and are interested in workshops, you can email me as well, or visit our website.